Welcome to this mini lecture on atherosclerosis. The learning outcome for this particular lecture is to explain the risk factors, pathogenesis, complications, and treatment/management of atherosclerosis. So what you need to do here is asking you to explain. So this is essentially how and why these particular things, risk factors, pathogenesis, complications, treatment management associated with atherosclerosis. So it's working with this particular pathology called atherosclerosis. Let's break it down. Athero meaning blood vessel, sclerosis meaning narrowing. So atherosclerosis is essentially in reference to the formation of a fatty fibrous plaque within arteries. So we got to stick to arteries only, and these are in reference to generally large, medium-sized arteries that are going to be both elastic and muscular. Sclerosis being narrowing or reduction in size, lumen. You need to explain how these things lead to this particular pathology. So risk factors, what increases the likelihood of this occurring? Pathogenesis, this is the pathophysiology. How does the pathology pathogenerate? Okay, and then complications, this is most notably systemic complications. So what happens in the body when you get atherosclerosis? And then finally, as a clinician, how do we treat it or manage it? Okay, so this is the take-home message. This is the learning outcome that you'll be assessed on for this particular mini lecture. All right, so we've done our definition. We know that atherosclerosis is essentially a fatty fibrous plaque within a blood vessel. How does it occur? What are the risk factors? The etiology? Well, these are the two that you need to think about. Non-modifiable, modifiable. So what this means is what can be reduced and what can't be as a risk factor. Non-modifiable means you can't really do anything about it. It's in the place, we can't remove it, we can't mitigate it. Whereas modifiable are things we can do. So regardless, in this table, these things that are listed here will increase the likelihood of atherosclerosis occurring. And it's important to note that each time you have a risk factor, it compounds the potential of it occurring. So for instance, if you were to have 2 of these risk factors in this table, your likelihood of developing atherosclerosis could be 4 times more likely. Whereas if you have 3 risk factors, it would be 7 times. And this keeps compounding on top of each other. To give you an example of what this really means, I'll just remove this here, is that a particular study, which I think was called the Framingham Heart Study, showed that if you were 55 years of age, regardless if you were female or male, if you had no risk factors, so you didn't have hypertension, you didn't smoke, you didn't have diabetes, you didn't have obesity, your lipids were okay, your risk of having a atherosclerotic complication, in this case it was referring to a heart attack, which is a complication of atherosclerosis in the heart blood vessels, your 10-year risk at this age, so 10-year risk was about 5.8% of some kind of ischemic event in your heart. Right. Now, what about if you start lumping some risk factors on? So again, 55-year-old person, doesn't really matter about sex at this point. So male and female are the same. 55 years of age. Now, if you were to have hypertension, if you were to have dyslipidemia, so you were to have a low HDL and a raised LDL, that would be dyslipidemia. You had type 2 diabetes, you smoked, and just to add one more thing to it, this is not so much atherosclerosis, but from a side effect of having hypertension, your heart was hypertrophied, it was oversized. Your risk now, 10-year risk of having a heart attack, was 58%. So highly likely that you would have a heart attack just by those additional risk factors. So hopefully that illustrates to you how important these risk factors are. Now let's just go through them quickly in context of atherosclerosis. I'll just remove this last bit. Okay, so let's start with non-modifiable. Essentially, age. How does age increase the risk of atherosclerosis? Well, this would be pertinent to 45 years for males and 55 years for females. And that will come into the sex difference in a second. But essentially, how age is a risk factor? Well, it just gives you more time for this process to occur. So the longer you live, the longer that this pathology is allowed to manifest. So age just really goes with that. And if you have other risk factors, it just amplifies the time that each one of those risk factors can build on each other for the pathology to develop. Now, sex, but biological sex, so males, it seems to be driven by testosterone. Testosterone seems to have an effect on lipids, on hypertension. They're probably the most important ones, which then predispose one. I'm sure there's other things, but that seems to be a strong effect. Whereas in females, estrogen has a protective effect on atherosclerosis. So it's very unlikely that a female premenopausal will have complications associated with atherosclerosis. So it's very unlikely that a female under the age of premenopause will have, let's say, angina or a heart attack or a stroke. It's just because the hormonal profile in a female is protective. Now, however, and this is where it gets a bit murky, if a female was to hit menopause and hypothetically to go on hormonal replacement therapy, the replacement therapy actually increases the risk. So it's better for her not to be on the hormonal replacement because that increases the risk of atherosclerosis. So it doesn't seem to be just estrogen on itself. There seems to be much more going on within the female, not just the estrogen. Now, finally, genetics. Genetics can be a combination of family history, a positive family history for atherosclerotic disease, or genetics that can predispose one to other risk factors like dyslipidemia or hypertension or diabetes or obesity. Okay, so genetics don't just work in increasing the risk of the atherosclerotic pathology occurring, but actually can feed into the other risk factors. All right, what about the ones that we can mitigate, the ones that we can control? Well, let's start with dyslipidemia. Now, in most books, you will see it called hyperlipidemia. Lipid meaning fats, emia meaning blood. So hyperlipidemia would mean high lipids in blood, which makes sense. Too much fats in your blood, not good. However, there are some fats that are actually important to be higher, and these would be HDLs or high density lipoproteins. So these are fats that actually take fat away from your blood vessels. So you actually want this level to be high, whereas the ones you want to be low is the low density lipoproteins, which are the proteins in your blood that are packed, have a small packing of fat in it. These are a high packing, high density pack. This is a low density pack. So you would actually want, ideally, for the LDLs to be low. Okay, other things would be triglycerides and just cholesterol. You would want these to be low. Okay, but in the risk factor, what would happen is it's not just hyper, it's disordered. So a dyslipidemic state would be a low LDL and a high LDL triglycerides cholesterol. Okay, that's why it's called a dyslipidemic. And so hopefully that makes sense. Hypertension is just really in reference to the amount of pressure in your blood vessels. So the more pressure, the more force that gets put on your sides of your blood vessels, and they're more likely to be injured chronically, which puts you in a state of inflammation, and therefore you start to put fat. Instead of like saying you have inflammation, chronic inflammation in your skin where you lay down collagen, chronic inflammation in your blood vessels lays down fat, and this is what atherosclerosis is. So hypertension actually just keeps putting injuries into blood vessels, therefore you're more likely to have atherosclerosis. Smoking, very bad for blood vessels among your lungs and all cells in the body, but smoking has many chemicals in it, and this can cause, again, injury to the blood vessel, the intima, but also can cause oxidization of the LDLs once they're in the blood vessel, which makes it a more nasty type of atherosclerosis. Diabetes in reference to sugars in your blood, as well as the liver making the sugar into fat, and so that's going to play around with your dyslipidemic state. So diabetes is going to cause the sugars to injure the blood vessels, but also probably pushes you into a dyslipidemic state. Obesity, that can cause chronic inflammation, which we see here, but obesity also predisposes one to dyslipidemia and predisposes one to hypertension, because you got more fat, more cells, more tissue, therefore you need more blood, therefore you need more blood vessels, therefore you need more pressure, therefore you have hypertension. So obesity fits into a number of them. Inflammation would be states where you are chronically inflamed. So certain pro-inflammatory states would be metabolic syndrome. So metabolic syndrome would be obesity with dyslipidemia, puts certain pro-inflammatory mediators, cytokines, into your blood, which causes a deleterious effect in other cells and tissues in the body, particular blood vessels. So this has been mapped to CRP levels, so C-reactive protein, which is a inflammatory marker that comes out of your liver. When these level is raised, it is an increased risk of atherosclerosis and heart disease. So inflammation chronically in your system has a greater risk of atherosclerosis. And then finally, lifestyle. This is referring to a sedentary lifestyle where not much activity, a very office-based job where you sit down a lot of the time. That would increase the likelihood of atherosclerosis, probably through the mismanagement of these. So if you were to exercise quite vigorously and regularly, your HD levels actually go up, whereas when you don't exercise so much, HDLs go down, LDLs go up. So there you go. They're the risk factors associated with atherosclerosis. Now let's move on to the actual pathogenesis. How does this condition form? Okay, so there's a few steps that you just need to be aware of, and this is why I've shown you the blood vessel here. So what I'm trying to illustrate here is different stages. Stage 1, stage 2, stage 3 into stage 4. So essentially, now many textbooks will do this differently. It's not really that important that you know precisely what stage is what, but you just need to know, generally speaking, how does it progress from a normal blood vessel, which we see here, into a very severe complicated plaque, which we see here. So step 1, essentially we need to have an injury, an endothelial injury. Then we go into a fatty streak, step 2. Then we go into a more a plaque. Let's say a plaque has established, a more established plaque, and then we go more to a unstable plaque. Okay, so this is the premise of what we want to work through for this particular slide. So let's go through this now. I'll just remove some of this stuff off. So the first thing you need to know is in the first blood vessel, this is arteries. It doesn't really matter which artery. It doesn't, at this point in time, we're just doing it as a generic. So here, we'll start here. What are the endothelial injuries? So what would cause, remember, this is an endothelium. The endothelium lines the arteries. So that's this stuff in here. Each one of these cells is endothelium. Okay. So what would cause a endothelial injury? And this would be chronic, which means it's ongoing. Well, the big ones would be hypertension. So that's too much pressure in the blood vessel. Smoking. Diabetes, I'll just put DM. Okay. and dyslipidemia. They're the big ones. There's others, and you'll find others in your textbook and other books. Certain inflammatory states, certain immune reactions, hypersensitive immune reactions, certain toxins will cause endothelial injury. But I've just listed the most important ones because these are the risk factors that are modifiable. So what actually happens is the endothelial injury occurs. So let's say hypertension, there's a lot of pressure in your blood vessel. And the blood vessel locations where these are most likely are the big flow vessels like your aorta, and where we have bifurcation points, where we have split in off into other vessels like carotid, like coronaries, like your renal arteries, like your iliac arteries in your legs. So the hypertension would put force onto the blood vessels. So that's bad. So that's force. Smoking chemicals that would annoy and injure the blood vessel, the cells, endothelial cells. Diabetes, again, the sugars can play around with causing kind of a glycosylation or an effect in the endothelium, which again annoys them. And the dyslipidemia, particularly the LDLs, can cause a disruption, particularly with the way that nitric oxide, which normally is released from endothelial cells to make the blood vessel nice and smooth. So how do we go from the injury into the fatty streak? Okay, so I'm going to remove this stuff up and zoom in. So let's assume that we have an injury to the blood vessels. So we have endothelial injury, which means that they're more prone to have things sticking to them. In one case, I'll just change colour. We start to see platelets starting to form. So we know that platelets will aggravate around blood vessels that are damaged, okay, because they want to clot it off. They can't distinguish between a broken blood vessel and an injured blood vessel. Another thing that comes along would be monocytes. So monocytes come along. Monocytes are the precursors for macrophages. And what starts to happen is these cells start to retract, which means they move apart from each other and there's more space. So what that will cause to happen is LDLs, which are in your blood, can now move in. So they can move into the middle layer of your blood vessel, okay, which is kind of between the intima and the media, and they start to accumulate in there. So now we're moving to the second stage, which is going to be over here. So stage 2, it's not a good colour, but stage 2 is fatty streak. Now, we all have fatty streaks in our blood vessels. So even children at the age of 1 will have fatty streaks. So it's not like it's an old age thing. It will happen regardless. So fatty streaks, and you can see in there like so, is just fat starting to deposit in your blood vessel. But what starts to occur is the monocytes starts to come in. So the monocytes, remember, monocytes are from your blood. They're a blood cell, comes into your blood vessel in the artery and start to accumulate around the fatty streak. What they will do, as well as these guys, which are smooth muscle cells, they'll move into that area and they'll start to gobble up the fat. So they'll start to chew up the fat and get filled, their bellies will get filled with fat, particularly LDLs, okay? And they start to oxidize. And the oxidization can be exacerbated by smoking. So this is why smoking makes it worse, which starts to cause the foam cells to form. So these foam cells are these fatty laden cells, which are monocytes become macrophages, and smooth muscle cells start to accumulate in there, which this over time, so years, decades, start to just make worse. It enlarges, so that means this is going to start to bulge out more and more. Okay, and this will happen over decades and decades. So the more risk factors you have here will just worsen this process. And that's why if you can mitigate the risk factors, the likelihood of moving from a fatty streak to a really fatty laden lipid atheroma is going to be increased. And this is where we're going to move now to the plaque. Okay, so step 3, stage 3 is the plaque formation. What really happens, the most important thing I just think you need to know here is the fat and everything associated with the fat just accumulates. So this is the fatty part or the lipid part of the atherosclerosis, just keeps manifesting in the blood vessel like so. Now, what makes it worse is that smooth muscle cells start to migrate and sit on top here, and they will start to, with the help of platelets that are kind of still sitting on the top here, secrete certain growth factors that bring in the smooth muscle cells, and the smooth muscle cells start to lay down a fibrous cap, which in a way is kind of good because it stabilizes it, which means that it's not likely to break. So it kind of stabilizes the plaque somewhat. But depending on how severe this blockage is will determine how much blood can come through this lumen now. So if this is a really fatty filled plaque, let's say it's out here, you may start to get symptoms associated with the plaque. So you might start to get less blood going through the blood vessel, and when you get a reduction in blood going through a blood vessel, you get a condition known as ischemia. So if this is in the heart, you may start to develop a condition known as angina. If this is down in your legs, you might start to get peripheral vascular disease, which gives you intermittent pain. If this is in your brain, or the blood vessel to your brain, you might start to get conditions where early stages of vascular clot issues. So let me get rid of this. Well, sorry about that. I'm not sure what's happened here. Going back. So the plaque has been reinforced by the fibrous cap. So at this point in time, it's relatively stable, but what we can see is the plaque has reduced, it's narrowed off the lumen. So now we have a much smaller lumen for blood to go through. Now, for many people, this might sit in the background for a long time, and it might be actually symptom-free. They don't know that they've got it. They may get a bit of chest pain when they exert themselves, otherwise they're not aware of it's happening. Now we move to the stage 4, which is the plaque that becomes unstable. Okay, so it's a real movement between this and this. So the main thing that happens is that the lining becomes unstable again. So like we saw back here with the endothelial injury, something happens again which knocks off the top cap. The top cap is this, which is the fibrous cap. It's kind of like a collagen cap that's made by the smooth muscle cell. And anything that can cause a little bit of injury on here, let's say, can start the process off. So an event, an emotional event or a physical event which puts an increase in hypertension in the blood vessel, this could just be a physical exertion or something that causes the person's blood pressure to go up. This can cause a little bit of injury to the cap, which then causes what to come along? Well, along comes the platelets. And as the platelets come along, what are they going to do? They're going to start to make a clot. And so the clot, this is fibrin formation, thrombin formation into a thrombus, and this can start to be the problem. So this can be either a clot that stays within the blood vessel. So let's say it's your coronaries. It starts to take up too much space, therefore no more blood can get through, and then we have problems with no blood getting to the heart muscle. There we get a heart attack. Or another thing that can happen is some of this could break off. So this, I'll just get rid of it. So go back to the clot. We have the clot forming here, but what happens is it actually breaks from here and then travels. So then it moves downstream. So this could go from the carotid blood vessel, break off, so that breaks off, goes downstream, which means it goes into your your internal carotid and then to your cerebral blood vessels, which then blocks it off and you get a stroke. Okay. Or it could go downstream and cause an MI in the heart. So this hopefully is illustrating how atherosclerosis can be a fairly benign process of aging, but moving towards more sinister effects based on probably the risk factor profile of the person. So what will happen? What will happen to the atherosclerosis? We know it's a blood vessel. We know blood vessels, arterioles more specifically, are the ones that are affected. But what are the ones that we really need to know? These are the complications. What are the main ones that we need to know that can cause the big problems? Well, here are some ones that you should know, memorize, retain to memory. Your carotids is one. You need to know that one. You need to know your heart, and hopefully you all know the blood vessels, arteries in your heart are the coronaries. Coronary blood vessels. Aorta is a big one. Aorta is a big one. Okay. And coming off the aorta is the renal, and then coming down to your iliac, going to your legs. So these are the big ones where atherosclerosis will become a problem. So we've already spoke about the carotids. So if you were to have a atherosclerosis in here, what that could do is either stop blood going to the brain full stop, or an embolus breaks off and travels up to the brain. So that's a problem with either TIAs, transient ischemic injuries, or strokes. Okay, so you need to know those. In terms of the blood vessel to your heart, well, these are little ones that are going down in the heart there, coming down here. So your left and right coronary vessels. So if these become occluded like that, what this can lead to is what we call ischemic heart disease, which can be broken into, broadly, angina, which is ischemia, and the MIs, which could be a non-STEMI and a STEMI, which is no blood can get past, and the heart will start to die. Okay, so that would be an MI. Equivalent to here would be the stroke in the brain, where the brain tissue starts to die. Angina, there's no death, but there's annoyance of the heart muscles because it's reduced blood, and this would be similar to the TIA in the brain. The most common location for atherosclerosis is the aorta, the abdominal aorta, just because it's got a high blood flow pressure. So you will likely to get atherosclerosis in the back wall of the aorta. Now that probably won't cause issues, but maybe in some individuals what can happen is the atherosclerosis leads to necrosis in the core of the atherosclerosis, which can then weaken the blood vessel, and we can get something called an aortic aneurysm, or sometimes they call a AAA, abdominal aortic aneurysm, which can then weaken it, bulge out, and then explode in an aneurysm, which can then lead to a rapid death because of such a big blood vessel. The renals come out of the abdominal aorta, therefore we have a bifurcation and a split, therefore there's more pressure and turbulence in the renal arteries, therefore you can get issues with kidneys, so kidney failure from that. Finally, iliac or femoral blood vessel issues can reduce blood flow into the legs, which leads to something we call peripheral arterial, or sometimes just peripheral vascular disease, which reduces blood flow to the feet. Therefore, feet are likely to become necrotic don't recover well from infections, etc. So that's another complication of atherosclerosis. Finally, how do we manage? How do we treat it? Well, it's all around reducing the risk factors, really. So what can we do? Okay, I'll just get rid of all this. So, sorry, this is a slow eraser. Okay, what are some of the managements? Okay, well, losing weight is a very important one. So weight loss, important because that will not only reduce obesity, but all the things associated with obesity like dyslipidemia, hypertension, but it also reduces systemic inflammation. We can get the lipids under control, so most commonly would be through diet. And if that's still too difficult, we can start to look at drugs like statins. So this regulates the lipid profile in your blood. Hypertension, we can maybe slightly reduce salt, because salt does have an effect in pressure, because water retention, therefore greater blood volume, therefore hypertension. So we could play around a bit with reducing sodium in diet. Diabetes management, so either preventing diabetes or reversing diabetes, particularly type 2. That's the only one you can really reverse, and that would be through weight loss and exercise. But if you are unable to reverse the diabetes or it's type 1 diabetes, you would want to maintain the sugar at a very good level on long term. Okay. Smoking, you definitely want to encourage your patients to stop smoking. That's a huge risk factor to get rid of. And lifestyle, you want them to move more. So exercise increases HDLs, as well as you want to decrease alcohol consumption or remove it altogether, because that does increase LDLs. So that would have a poor profile on the lipids. Now, there's many things we can do, but these are just some examples. Obviously, we can't play around with these, so they're things that we can't fix, but a lot of the modifiable can be done. Now, if the atherosclerotic plaque is too severe, so let's say we're working in this end, we can't really reverse that too much. We may actually do some surgical interventions. Let's say in the heart, you may want to do angioplasty, where essentially you put in a tube into the blood vessel and you might either squash to make the blood vessel open, or you may stent it to keep it open, or if it's just bad enough, you may want to bypass it, which means you go over the top of the plaque. All right, that's it. Hopefully you can now do all of this. Hopefully you now can explain the risk factors, how it develops, what are the complications, and how treatment and management for atherosclerosis can be managed. Thank you.